Good afternoon, everyone. I'm happy to introduce our first speaker, Dr. Tolentino. He's an associate professor of internal medicine and pediatrics at the University of Miami and serves as a program director of the medicine and pediatrics residency program and the director of the Path Transition program here at the University of Miami. He graduated from the Medical College of Georgia and completed his residency training at the University of Cincinnati at Cincinnati's Children's, where he completed a fifth-year medicine and pediatrics chief residency. He has over 15 years of experience in graduate medical education, including serving as an assistant program director for the medicine pediatrics residency program at the University of Cincinnati and program director of the medicine pediatrics program at Stony Brook. He has clinically worked in transition medicine for over 15 years, working clinical programs targeting the care for young adults with special health needs, cystic fibrosis, and adult survivors of the childhood cancers. He has served as a director of the PATH program since its inception in 2022 and serves as a team pediatrician for the multidisciplinary Jackson Pediatrics Spina Bifida Clinic. He's authored several books, sponsors several books on transitional care and serves as the National Guidelines Committee for Spinal Bifida. He is part of the Lifespan Working Group in the Mailman Center, focused on the care for adolescents and young adults with developmental disabilities.
All right, thank you so much. Thank you for that wonderful introduction. First off, I want to thank everyone for joining us today, and thank you to Dr. Weiss and Dr. Brown for letting me speak about transitions. And today I'm going to talk a little bit more about defining what outcomes for a good transition looks like, especially as we think about patients that go from pediatric to adult care. So at the end of this presentation, I'm hoping that you guys will be able to identify systems of care for transitions for patients going into adult care, identifying the 6 core elements in transitions, as well as evaluating the medical and psychosocial outcomes for young adults with developmental disabilities entering adult care. And I have no financial disclosures unless anybody wants to give me any. So let's meet Diego. So Diego is a 19-year-old patient, first coming to me in PATH Clinic, previously by his pediatrician, developed pediatrics, genetics, and pediatric neurology, and was just told, you need to see an adult doctor. So he came to my clinic, no information, no summary. When I looked in care everywhere, no information was available. The patient's parents came in saying, I just thought I would just see my doctor forever. And came in a little confused, but very overwhelmed. Mom did note that the biggest issues right now is very impulsive, lots of unintentional harmful behaviors that have really increased over the past several years, scratches parents, therapists, and spitting on others as well. And sometimes we'll pull on his hair for what mom thinks is sensory stimulation. And at times, family has to restrain him just to calm him down. And when he's at school, he screams at his classmates, but for the most part behaves and doesn't harm any classmates. When you look at his past medical history, mom's able to tell you that he does have Fragile X, seen by genetics. His autism, he's been seen by developed pediatrics. He has some hypotonia. He has seizures, which mom says is for the most part well controlled by his pediatric neurologist, but is notably nonverbal. So he's on valproate 10 milligrams for his seizures. He's on sertraline, which is used for patients with autism very often. And he has no allergies, except mom says when he ever takes Benadryl, it's usually the worst day of our lives, and has a really terrible paradoxical reaction. Does get behavioral therapy, mom says for 5 hours per day, but no other equipment is really needed. But when you sit down and ask mom a little bit more about the social history, aside from being in high school, which they plan through 22 years of age, mom has talked to vocational rehab, discussing potential work and other developmental things. But mom's primary concern is that he can't work because of his behaviors. He did talk to a transitional service coordinator of some sort in the last year when he was 18, but that was only one conversation. And most notably, mom has not started any guardianship paperwork. And when she looked into a lawyer to assist, it was going to cost her at least $2,000 to $3,000. And when she inquired of legal aid, it was going to take at least a year to get off the waiting list. So that process was probably going to take the next 2 to 3 years. And he's been getting services through Medicaid in the schools, but no longer in ABA therapy, and does get some speech therapy through the school. And so when you try to do your physical exam, you notice that he was tachycardic. You're unable to get a blood pressure. He's pacing in the room, but he's redirectable. He is nonverbal, and occasionally he's screaming. You can't really do an HENT exam. The rest of your exam is pretty limited because he's very anxious, but more importantly, he kind of pushes you away constantly. Somebody got labs on him in the past year, and the labs are pretty much unremarkable. So this is my typical patient that I see in my path clinic. And a lot of times I ask myself these questions is, did this patient actually transition to me or did he just transfer to me? And did this patient actually come ready? And was this really successful? We always talk about transitions, but he just came to me and mom is overwhelmed, the patient's really poorly controlled. And when they come to us in transition clinic, transitions doesn't start at 19, but they just kind of showed up. So did this intervention actually work? And what does a good transition look like? And so when we think about transition medicine, we think about a lot of these patients with diseases that start in childhood, we think of things like autism, and a lot of patients have lots of care needs all throughout their childhood. And they had lots of psychosocial issues that really affect their overall outcomes. But they all go through adulthood. And unfortunately, transitions, and this is my only sports reference I'll ever put into any of my lectures, it's like a Hail Mary pass, right? You just hope that somebody in adult medicine will catch them and figure that out. And unfortunately, that's a real problem because if you think about the number of young adults in America, there's some 64 million, 22 million in that 20 to 24-year-old range, but 15 to 20% of young adults have some sort of special healthcare need or chronic medical condition. 4% have functional limitation. But one of the things that's most remarkable to me is that for many young adults, whether you have a developmental or special healthcare need, their most common, one of the most common uses of the emergency room is this patient population. So a lot of times we talk about transition support, but the data will bore out that we don't do a great job of transitioning these patients, and a lot of healthcare costs end up being increased. And we know that in pediatrics, we've done an amazing, absolutely amazing job when we think about how good we are actually getting these patients to adult care. In the 1970s, many of these chronic diseases were diseases where mortality occurred in the second decade of life. Now, most of these patients are actually able to live through the fifth or sixth decade of life. That's amazing. We've done a really, really great job of that. But what we haven't done a great job with is really thinking about how we transition these patients to adult care and do it in a way that actually maximizes outcomes. Because the big thing I always emphasize to my residents, to medical students who come through to me, is that transition is a process and it just doesn't start on the day that they come to adult care, that it occurs longitudinally throughout pediatric care. The most common way I think about framing this is pediatric patients have a much better transition process to college than they do to healthcare. Many of us have talked about where our children are going to go to college starting at 2 years of age, 3 years of age, and we're thinking this guy is going to go to UM, right? And we get him pumped up going to UM, we get him prepared for college, we get him prepared to being independent, but then we never think about, but you're going to see an adult doctor because you have asthma, you have cerebral palsy, but we're going to make sure you go to UM as much as we can. So what we want to really reframe is thinking about what does transitions actually look like if we started early. And back in 2011, a joint report came out from the American Academy of Pediatrics, American Academy of Family Physicians, as well as the ACP, looking at what that process would look like. And I think one of the most remarkable things about transitions is that we're thinking about starting this at 12 years of age. And that we're thinking that not only are we getting them to adult care, but we're preparing them for adult care. So the six core elements of transitions starts with having a policy and really understanding that transition started in that 12 to 14 years of age. You're tracking and you're monitoring how a patient is doing. You're also assessing what they're ready for, and you're actually developing those skill sets as they become increasingly more ready, and you're planning for it. You're actually discussing with families who are you going to go to, who's going to be responsible for certain things, but more importantly, how are we going to prepare this patient for independent life and for adult medicine before we even do the transfer of care. And as you can see, this starts at 12 and there's very distinct steps, but this goes all the way through to transfer at around 22 to 24 years of age. Now, when we think about outcomes, again, going back to our initial question is, this is the process, but the process doesn't necessarily mean that it improves our patient outcomes. And so while we look at outcomes associated with the transition process, it does feel like a checklist. And what I really want to discuss a little bit more about today, especially in the context of this patient, is what does it mean in terms of like disease-specific control and really being able to see what are those patient-specific disease outcomes that we can kind of look at. Now, one of the things that I always want to emphasize with the transition process is that it is very jarring for patients, and the more we can um, prepare them for this process, the better. A lot of times we think about the transitions as being like a big breakup with your pediatric provider. And not only prior to, but during, and the lack of support, the lack of communication, and just the difficulties between the adult and pediatric systems really leads to a lot of discontent, but really unhappiness with the overall transition. But a lot of times families talk about the loss and the loss of going from pediatric to adult care and how impactful that is. And many people in my clinic will even come to me and say, gosh, I wish that this was still like pediatrics. And I keep saying, well, yes, but your child is now an adult, and we have to really start reframing our conversations about what it's like to be an adult with cerebral palsy or autism. Because we know that poor health outcomes have been identified amongst autistic adults when you think about general mortality and morbidity, from early death and mortality to increased rates of emergency department utilization to less use of preventive care services, and in some studies even looked at utilization and cost, and it is higher amongst the autistic population, especially for this particular patient. And so um, we know that if we think about can we change this through the transition process, this is one thing that we kind of really are trying to do with some of these programs. Now, on top of that, we also know that there are certain patient characteristics that are associated with better outcomes with transitions. We look at IQ, especially patients with lower IQs. A lot of activities of daily living, if they're better prepared and they better understand it, they have better outcomes. And those with higher IQs, when we talk about the community domain, we talk about the community networks that they exist in, as well as its severity of autistic traits and adaptive functioning. What's interesting is that we know that other weaker predictors, such as behavioral and emotional problems or overall language development, may not be as strong of a predictor as we would expect for outcomes. But we know that inherently there are going to be certain patient characteristics that can be associated with better outcomes. So let's talk about the process first. And we know that indicative successful processes for transitions have looked at things like scheduled visits, follow-ups, ability to self-manage when they actually see their adult providers for the first time. And when we look at some of these outcomes, we can track these and they're a little easier to track. But unfortunately, what we do know is that one, some of these are very provider centered. They may not necessarily improve the actual patient experience, but the other part is that quality indicators may not be as strongly linked to certain conditions like mental illness and developmental conditions. And so when we look at disease-specific outcomes at the patient level, there are some, especially for things that we can easily track, such as diabetes and hemoglobin A1Cs, transplants, and tacrolimus levels and renal function, sickle cell disease, and hydroxyurea utilization. Um, we do have outcomes, and we've been able to show that transition programs have been able to actually improve some of these disease-specific outcomes. And again, there are all these other process outcomes that we've looked at for patients with chronic diseases in childhood. And transition programs have been shown to be helpful from that standpoint. And when we overall looked at quality of life and healthcare utilization, a lot of the literature does suggest in general that transition programs can improve many of these markers. But I think the difficulty with a lot of the research right now is that we don't actually have a clear understanding of which transition processes improves which certain outcomes, and we still don't have much information about how this actually links back to developmental disabilities as well as mental illnesses. So when they did look at, particularly for patients with intellectual disabilities or autism, um, there have been a myriad of different studies, and I'm not going to go through every single one of these, but various different studies with some strength associated with each of these studies have looked at general outcomes, comorbidities, mental health, self-management, independent living, and cost. But when I think about looking at these individual outcomes, um, most of the literature is suggestive as to are these good ways or are these effective ways of actually looking at these outcomes. But the other part that we've also recognized is that I can't tell you which outcomes are strongly linked to certain transition processes, or if transitions has a good transition program and a good transition actually improves certain amounts of these IDD outcomes. So Freeman and her research team actually looked at all the different outcomes and actually put together a set of recommendations associated with what are the things that we should be looking at when we transition patients, especially with developmental disabilities, from pediatric to adult care. This is a busy slide. The one thing I really wanted to kind of point out is that when we look at for condition-specific outcomes for patients with autism, um, there are different measurements that they suggest that we start to look at. But the one thing to really note is that a lot of them are associated with comorbidities associated with autism, such as fatigue, epilepsy, and gastrointestinal concerns such as constipation. We continue to look at a lot of these other outcomes for IDD transitions, but much of the literature still is fairly weak as to what constitutes a good outcome in transitions. And this is an area of further study that many of us in the transition world are continuing to look at. But what has been seen in terms of specific elements that is associated with better outcomes are things such as appropriate parental involvement, meeting with the adult team before transfers, efforts to focus on self-efficacy and self-determination studies. But again, the experiences for ID population still lacks the standard measures. And one of the things that, again, we talk about these transition clinics and these transition programs, but there aren't that many. There are about two big transition programs in the state of Florida. Ours over here, the PATH Clinic, and there's another clinic up in Jacksonville that does it, but we obviously cannot serve the entire IDD or autism population for the entire state of Florida, and there's still a lot of need out there in general. Now, I wanted to speak very specifically about the autism spectrum disorder in terms of some of the comorbidities that exist. And the one thing that I think is really important to remember with autism is that autism is a developmental disability that has many medical, developmental, and psychiatric, as well as social comorbidities that are ripe for really great markers for outcomes. But a lot of them still need to be studied and really need to be studied from the standpoint of can we actually improve some of these outcomes, and what are the outcomes that are the best markers for transition? I think the most common one that we think about from a medical standpoint are things like seizure disorders. There's a very high association with seizures in patients with autism, and really thinking about how to improve overall seizure control. We do see a lot of patients with sleep problems and constipation. From a developmental standpoint, we think about vocational considerations, their ability not only to participate in vocational programs, but being able to actually hold down as well as maintain a job through the transition. And then we think about other social outcomes such as guardianship, financial responsibilities, and independent living. And these are areas that we continue to really develop. And one of the biggest comorbidities is the psychiatric. A lot of our patients with autism do have a lot of associations with ADHD, anxiety, and depression. We know that the process that many of our patients with anxiety and depression um, uh, really struggle not only with independent living because of these comorbidities, but they often also develop a lot of problems with being able to interact with the rest of the world. And so this is one of these areas that is ripe for a lot of research. Now, there are some interventions that we've looked at for autism with some of these comorbidities, in particular with mental health and anxiety. Cognitive behavioral therapy, mindfulness interventions have been shown to be effective. There are some pharmacologic studies that are looking at this as well. Um, we often extrapolate our use of medications interventions from patients without autism as a way to kind of manage a lot of our patients with anxiety. But a lot of it is now being studied right now. There's a new Strata study looking at the use of sertraline in autism. Patients with Fragile X have been found to be show improvement in language function and overall anxiety um, uh, when using sertraline. And so these are areas ripe for ongoing study. Other things like aggression and behavioral symptoms with mindful interventions have been shown to be effective, and overall quality of life. When we think about social skills, programs such as Peers or Project Search, which are really focused on self-determination and social skills, have been shown to have not only good psychosocial outcomes, but really assures consistent employment. So let's go back to Diego. So what happened with Diego? So for his aggression, we started on risperidone, 1 milligram at night, and we continued his sertraline to help with his what we suspected is some underlying anxiety associated with aggression. And we discussed a transition plan for his specialist, something that had not been discussed before, and we started looking at again. For his vocational needs, we actually got him connected with the Center for Autism-Related Disorders, an organization that's actually based here at the University of Miami, as well as Nova Southeastern University, to really address, can we build some of his vocational needs, even with his behavioral issues. And then from our social worker, as part of the PATH program, addressed guardianship, social programs, additional benefits such as Medicaid waiver, and mom overall expressed satisfaction, but still seemed very overwhelmed at the visit. And we continue to follow up with him on a monthly basis. And actually, this particular patient I've been seeing now for the past several months, and I see this family every 2 weeks because they have so many needs going on. So in the end, did this patient have a good outcome? Did the transfer of care or the transition of care actually work? And again, this is another example of a transfer of care. The family came in unprepared for any type of transition, and but what we recognized was that we started the transition for him, and that coming into the transition clinic, although it seems somewhat late, we worked really hard to get him caught up as quickly as possible. So our path clinic was able to facilitate many of the things that we needed to get started several years ago at this visit, even though he had very little planning. So when we think about outcomes, like disease-specific outcomes in this particular patient, and the big one is mostly going to be associated with his overall behavior control. It's a little early. We're hoping that our interventions will work. But this is one that we're going to continue to work on for the next several years. The one thing to remember is that this was a transfer. This was just part of the transition process. And so success and several experts really focus on when it comes to success, even with appointments, we need to follow this out for the next 2 to 3 years before we really consider this a transition success or transition failure. And then finally, the patients were satisfied, the families were satisfied, but we still have a lot of work to do. So just really briefly, just real quick about the PATH program. We are a program focused on adults with intellectually disabled and the development disabled comorbidities. It's a coordinated program, interdisciplinary. We're very lucky to have a social worker, a peer navigator, as well as a team including our division chief, Dr. Brown, Dr. Thorson with genetics, Pima Nar, as well as adolescent medicine, all working together to really assure that many of these patients, even those with late transitions, are able to get the best outcome possible. And the one thing that we really focus on when it comes to patients who are transitioning is that we are trying to keep this space as autism friendly as possible when we're addressing the sensory needs, the predictability that a lot of autistic patients need, acceptance of their disease process, the communication processes that is needed, as well as empathy that is necessary for not only the patients, but their families themselves. One last little bit I do want to promote is the new feature in UChart, which is the track questionnaire, which allows anybody who sees patients with autism or any developmental disability or any chronic disease. This is the track questionnaire, which allows you to actually address skill sets and to also determine what skills patients need to work on. Even if they come to you as 18, 19, 22, 24, it's a way to kind of assess where a patient is in their overall transition process. It's wonderful that we have it integrated into UChart now, and it's something that I encourage all physicians who care for diseases that originate in childhood on a regular basis. So with that being said, children with disease of childhood origin continue to age into adulthood. General and so specialist internists will need to develop process and expertise in managing these patients. There are guidelines that are currently available to help guide providers and patients, but process outcomes exist, but more research is really needed to identify clinically relevant outcomes in the IDD population. With that being said, thank you very much.
Thank you, JT, for making us aware of this really important and very topical subject. Of course, they're going to cure autism. Of course, for our president. But, two quick questions, and a lot one could ask. I'm a little concerned about that heart rate of 145 when he
Yes.
showed you. Did that sort of slow down at some point? Was it just anxiety? And did you follow that up? And if so, how do you manage that, in the clinic at the time?
So yeah, that's a great question. Yes, so the heart rate did improve over time. What we find with a lot of patients who come in with autism, the actual presentation in a new clinical environment is very stressful. So what we spend a lot of time doing is actually trying to meet where the patient is. So patients who are tachycardic are very anxious. Sometimes we'll do the visit in the lobby. Sometimes we'll do the visit wherever they end up, where they feel the most comfortable. For him, what we did is we actually removed him from the room, allowed him to walk around for a little bit, and then come back, and he calmed himself down with a lot of redirection.
And also, I noticed that the patient's diagnosis, actually his genetic diagnosis, was Fragile X, and you didn't mention that again. You just called him autistic. And the treatments really were symptomatic treatments for the most part. Is there any role in specific genetic diagnoses, and how would you handle that differently in a more personalized medicine approach to these patients?
That's a great question. So yes, especially in the world of transitions with IDD, there's a greater recognition that genetic disorders are associated with many patients with with autism-like features. This is actually part of the reason that we partner very closely with our department of genetics for many of our patients, and doing whole genome sequencing and what have you for patients who are diagnosed, especially with any physical features that may suggest of a genetic disorder. That does allow us to better handle management. This is part of the reason why we started on sertraline. Sertraline has been shown to actually improve language outcomes in patients with Fragile X, and it really allows us to better personalize their disease process.
Thank you very much.
Of course. Thank you.
Good afternoon, everyone. So our second speaker is Dr. Lekakis. He's a hematologist with special interest in allogeneic stem cell transplant for leukemia and in cellular immune therapies. He received his specialty training at Yale and MD Anderson Cancer Center. He serves as the local principal investigator in the trial that led to the first FDA approval of a CAR T product in lymphoma, and another one that led to an approval of CAR T therapy as a preferred second line for treatment in diffuse large B-cell lymphoma. He is also brought to the University of Miami for first-time trials of cellular immunotherapy for solid tumors, and CAR T for rheumatological diseases. He has done clinical research with allogeneic CAR T products as well, and he's performed allogeneic transplants in patients with sickle cell disease. One of his main interests since the beginning of his career, approximately 20 years ago, was the treatment of graft versus host disease, where he's taken care of hundreds of patients and has done both clinical and laboratory research. Dr. Lekakis has performed more than 800 stem cell transplants and CAR T cell infusions at the University of Miami, where he serves as professor of medicine. Please welcome Dr. Lekakis.
Hi, everyone. We'll talk today about an experimental approach of using CAR T cells for autoimmune diseases. And those are the conflict of interests. I have been served in advisor boards with those companies, Allogene, Kite, and Sanofi. And I have been supported by Kite, BMS, Allogene, and Autolas to run trials here. So today's objective, the first one is how we need to figure out how we make CAR T. Some people may not know. What are the toxicities of the CAR T, and what is the concept of resetting the immune system in autoimmune diseases with CAR T, and we'll go over the first results that we have available. Again, this is an experimental therapy, is not FDA approved. Those are the partners in crime. Dr. Carpintero and Dr. Corbett have been co-investigator in the trial that we have here, and they have helped us a lot because I have no idea how to evaluate those autoimmune disease patients. And in terms of CAR T, how we make it, so first we take lymphocytes out through leukapheresis. We send them to the company, to any company. They activate the T cells, and they put, let's see, they put a viral vector with the CAR, the chimeric antigen receptor. And in this case, in the lower part here, you see an anti-CD19 CAR that, is this a laser here? Maybe? No. Let me go back. Is the top one the laser? Maybe. Maybe. The CAR, what is the CAR? Is a variable fragment of the immunoglobulin receptor that recognizes, in this case, the CD19 on B cell. And then there are other parts, but the most other important part is the co-stimulatory domain. They don't work well without co-stimulation. They expand the CARs, and then they bring them back. We give lymphodepleting chemotherapy to the patient, usually with fludarabine and cyclophosphamide, to create lymphopenia and take advantage of lymphopenia-induced proliferation of the CARs. And then they start expanding in the body, and they go and kill the target. In this case, for example, the B cells. And we have tried it in lymphomas. We participated in the first trial that led to the approval of oxycaptagene ciloleucel in lymphoma. This was the first product approved in lymphoma in the United States. And we accrued a lot of patients, but apparently patients can respond dramatically. Even patients who have been multi-refractory, for example, this patient here had received 7 lines of therapy, had ECOG performance of 3, pulmonary embolism, biliary catheter, and let's try this. Apparently, this is sugar going to the tumor, and 1 month after the CAR T therapy went to complete remission. This goes with the product that we use, the oxycaptagene. Obviously, this one comes with toxicities. There is a war in the body. The CAR T try to kill malignant tissue, lymphoma or acute lymphoblastic leukemia, or normal B cells. So there are a lot of cytokines released, interferon gamma, TNF alpha, interleukin-6, and they create the so-called cytokine release syndrome that drops the blood pressure, creates fevers, and we usually treat it with tocilizumab, a monoclonal antibody against the IL-6 receptor, and steroids. Also, patients can develop encephalopathy. This one can be aphasia, apraxia, stupor, and can go to seizures, brain edema. I have lost a patient from brain edema. And the treatment is steroids and anakinra, interleukin-1 receptor antagonist. Some patients develop cytopenias, heavily pretreated, too much inflammation causes injury on the bone marrow, and they can have prolonged cytopenias for months. They can develop too much excitement and go to hemophagocytosis, and almost all of them, they develop hypogammaglobulinemia. So in many of them, I have to replace immunoglobulin with IVIG. Now, we use also CAR T nowadays for myeloma. And the target there is the B cell maturation antigen, late maturation antigen, the so-called BCMA. So we have reported among the first, we reported enterocolitis, and the first paper, of course, my patient's picture on the paper with ruptured bowels and stuff. And we have seen a delayed neurologic toxicity. And I had the patient who developed even necrotic areas in the brain. Delayed neurologic toxicity usually is Parkinsonian-like syndrome. Guillain-Barré has been described, thanks God we haven't seen it here, bilateral Bell's palsy. I have seen all the cranial nerves can be affected. And the reason is that the BCMA is also expressed in low quantities in the brain, and especially in the caudate nucleus. And we don't even know how to treat exactly those conditions, but we try to kill the CAR T cells. We see a lot of infections. All right, that's about malignant diseases. Now we go to the autoimmune diseases, and we are not unfamiliar, the cell therapists, stem cell therapists here with those diseases, because we have used autologous stem cell transplant, high-dose chemotherapy with autologous stem cell transplant to reset the immune clock, to reset the immune system and stop the inflammation. So the classic paper is in systemic sclerosis, that they compared monthly pulses of cyclophosphamide for 12 months with high-dose Cytoxan, only 2 doses, and total body radiation at 8 grays with ATG and CD34 selection. Yes, it's a hard treatment. You seal the lungs to not get radiation pneumonitis, but at the end of the day, I don't know any other therapy in systemic sclerosis to be more effective than this. In the trial, which was a prospective trial, there was an overall survival benefit. Do we use it here? No. They have tried the same thing in lupus, and in very refractory lupus 20 years ago, they had very good results, and here they did not use radiation. But again, the trick, I think, here is the CD34 collection. You don't want to give the pathogenic lymphocytes back to the patient. So we go to the first paper now that brought the interest to medicine about this thing. It was a New England Journal of Medicine paper, and the people from Germany, George Sett is the responsible probably for this thing. They used a Miltenyi product, anti-CD19 CAR-T with 4-1BB co-stimulatory molecule. And they took patients with very refractory autoimmune diseases, and they treated 15 patients, and at the end of the day, all of them went to a steroid-free state without any other immunosuppressive medication. 8 patients with lupus, 3 with myositis, and 4 with systemic sclerosis. I take here the patients with lupus on the first slide, and you see here the activity of the disease went to 0. The DS, the double-stranded DNA, 0, and with their product. And in inflammatory myositis, CPK came back to normal level. The strength of the patient improved, and in systemic sclerosis also the activity went down. As I told you, we see a lot of hypogammaglobulinemia and B-cell aplasia after CAR-T for lymphoma, but didn't happen here with CAR-T for autoimmune diseases. So they regenerated B cells. And the B cells that they regenerated, they were naive B cells, and not as much memory B cells. And this is the concept here. They regenerate their immune system with naive B cells that they do not cause, they don't remember how to cause the same autoimmune problem as before. And you don't need to give them IVIG. What I did here, I wish to know. I can see it here, but not there. Maybe I do this. Of course, it happened to me.
turned off for powering on.
Sorry about that. Excellent. All right. So the question here is how far can you go? And they have done it even in patients with class 4 diffuse nephritis in a lupus patient who was dialysis dependent, treated before with almost everything under the sun. And patient not only was treated successfully, but became dialysis independent. The same group, they published it in Lancet. They had a patient with transverse myelitis from CNS lupus, and I didn't put the video here. The patient was paralyzed in bed, paraplegic, I would say, in bed, and he started walking again. And those were very impressive. Now, I saw also an interesting article. I thought that ulcerative colitis is mainly a Th17 disease, but they use anti-B cell CAR-T, anti-CD19 CAR-T, for refractory ulcerative colitis. Now, this ulcerative colitis obviously had failed TNF alpha antibodies, IL-23 antibodies, alpha 4 beta 7 antibodies, and vedolizumab, infliximab, all of those, and it was refractory. So they gave CD19 CARs, and the patient responded, and you see it macroscopically here and microscopically here, regeneration of the glands, and the inflammation went down, both systemically, the C-reactive protein came down, and the fecal calprotectin came down. They have tried it in neurologic diseases, so the patients with myasthenia gravis, we did it here among the first, Dr. Pereira, with anti-BCMA CAR for myasthenia gravis. I remember I went to the room to see the patient when developed the neurologic toxicity. But anyways, so they have tried it successfully to treat patients with myasthenia gravis who have failed almost everything else. And this is the trial that we do. So we participate in a trial here of BMS using in vivo expanding CAR-T. Again, apheresis, activation, put a CAR inside the T cells. They try to do a little bit of expansion ex vivo, and then they give it to the patient after fludarabine and cytoxan lymphodepletion. And so we have in vivo expansion. The turnaround time is only 1 to 2 weeks at the most. So we try to treat. The trial included patients with lupus who had failed with BILAG A score lupus, who had failed steroid and 2 immunosuppressives, myositis, again, failed steroids and 2 immunosuppressive, and systemic sclerosis, who had failed at least a trial of 3 months of 1 immunosuppressive therapy. And the primary endpoint obviously was to find the phase 2, the recommended phase 2 dose for each of the 3 indications. Now the data that I presented before, the cutoff was March of 2025. There were 33 patients infused in the United States. We put only 2 patients here on the study. We had other referrals, but were not eligible. 19 patients had lupus, 9 sclerosis, and 5 myositis. Those patients in this trial that we do here were heavily pretreated, and 7 lines of therapy, the lupus patients, median, and 4 lines, the myositis patients. and they had very high activity of the disease. The modified Rodman skin score here for sclerosis, the median one was 34, for example. Now, do they work? Do they expand? Yes, they do. They compare the expansion of those CAR-T that we use here, the in vivo expanding CAR-T, compared to a historic product that we do the expansion only ex vivo, and the expansion is the same. So they do expand. Are they doing what they are supposed to do? Yes. They kill all the B cells here.
So is that one now?
And
Can
then,
someone answer?
the good thing here again is that the B cells are regenerating. So you don't have, usually, I have a patient with B cell aplasia, and I have to give IVIG. But the B cells usually come back. When they come back as naive. They don't come back as memory. That means that you have killed the pathogenic B cells, and you have a new immune system, a new B cell immunity. Now, in terms of toxicity, there were 4 cases of ICANS, of neurologic toxicity, and one of the worst, of course, we had it here. There was one grade 3 renal toxicity, all of them reversed. So one patient apparently developed grade 3 encephalopathy with steroids, and the whole thing resolved. Another one developed seizures. That one, it was not the one here, but after pulse steroids and anakinra, this was resolved. And after all of those things happened, we decided to give only 10 million flat dose, dose level 1 to all the patients. Now, in terms of efficacy, I take here the lupus patients, and you see that the SLEDAI score got down by 10 points, and all patients with lupus remain to date, or at the last follow-up, free of corticosteroids. The dsDNA went down, the complement went up, so in summary, we have the trial that we ran, again, is a phase 1 trial that we already found the recommended phase 2 dose. The safety shows good safety profile, except without grade 4 toxicities, but we need to know how to treat grade 3 neurologic toxicity. This is the main problem of this particular product. We had robust CAR T cell expansion. We had complete B cell depletion. Then they came back with a naive phenotype. And you see here some pictures before and after. In a patient with lupus, the skin cleared from the rash. The activity, very encouraging. Most, if not all, patients have been immunosuppression free. All right, what is the current status? And this is the most important slide of today's presentation. So yes, we know now the dose. The trial is still open for myositis patients. So if you have someone with inflammatory myositis, refractory to steroids, and 2 more lines of immunosuppression, send the patient fast, because it's very competitive trial to accrue. We have a new cohort with lower dose of lymphodepleting chemotherapy, only 1 dose of fludarabine and 1 dose of Cytoxan, of cyclophosphamide, for lupus patients. So if you have a difficult patient with lupus, send the patient to me. We open a new cohort for rheumatoid arthritis. I have sent to the rheumatologist the inclusion criteria. And now that this was the phase 1 trial, the IRB just approved our phase 2 study for severe lupus-only patients. And we have a trial coming up. We were accepted as a center, a phase 3 trial for systemic sclerosis that will compare the CAR T versus conventional therapy, especially with systemic sclerosis and interstitial lung disease. And they have specific drugs on the control group. All right, so thank you for the tolerance. I didn't finish yet. I have some backup since I have little time. So this is my cell phone, this is my email to refer me patient. I want to show you something interesting. So we went from transplant to CAR T. Can we do even, what happens if someone relapses after that? So this was Nature Medicine paper. One of their first patient relapsed. And they treated again with CAR T, didn't expand the product against CD19, and they gave a third CAR T infusion. This time, the CAR T was against the BCMA to kill plasma cells that were producing the antibody. So can we do even easier treatment than CAR T? Now we have a medication that's approved in myeloma. It's called teclistamab. The target, so this is a bispecific T cell engager. One arm sees the CD3 on the T cell, the other arm sees the B cell maturation, late maturation antigen on the plasma cell, bring the T cell to the plasma cell to kill the plasma cell. Very effective in myeloma. So they treated patients with this, with refractory lupus. And as you see here, the plasma cells disappear. And not only plasma cells, but some of the late memory B cells also express BCMA, and all of those almost went away. And the complement went up, the dsDNA went to 0. Now, they reported in New England Journal of Medicine 4 more patients with a significant improvement. On the current issue of New England Journal of Medicine, there is another series of teclistamab for 10 patients with autoimmune diseases. And there is one more interesting paper in the recent issue of New England Journal of Medicine, in vivo CAR T. So the Chinese put bring the CAR inside the body with a lipid nanoparticle, and this goes and finds the CD8 cell, and this can kill B cells and can help patients with autoimmune diseases. So the whole thing is expanding, and we may be able to just give few doses of a BiTE or a few doses of a nanoparticle, lipid nanoparticle, in order to give a benefit to our refractory autoimmune disease patients. Thank you.
So Laz, thank you very much. I think this is a great example of how cooperation between different disciplines in the Department of Medicine can advance science and advance medicine amazingly well. So looking beyond cancer, there's lots of other things that our division of stem cell and transplant biology can look at. So this is great. I'm wondering though, it seems as though it's sort of like one bullet for multiple diseases that can be very, very heterogeneous, not just in terms of their clinical presentation, but also in terms of perhaps their immunology that we don't even understand. So is there a time when you think our specificity for the antibody is going to be improved, where there'll be more specific and less side effects in terms of the efficacy for these?
Thank you for the question. So it's difficult to target the T cells, because then you create a severe immunosuppression and you don't know when and how they will come back. So this is why they target the B cells. So we have the anti-CD19, we have anti-BCMA that targets both late memory BN and plasma cells. Now we lower the dose of lymphodepleting chemotherapy. and we learn how to treat the complications more effectively. We try to improve. Yeah, I don't know what else to say.
Okay, well, thank you very much. Dr. Green, do you have a comment? Thank you. I think that's a great plug and a great way to end today's grand rounds. I remind everybody to check the QR code to get your MOC and CME, and look forward to seeing everybody next week. And I thank our speakers again. Lazo was great. Thank you. Thank you.
Thank you.